Good morning or good afternoon on the East Coast, and thank you for joining us for this update to cover telemedicine virtual visits, e-visits during this COVID-19 emergency. I do want to thank all of you for your attendance, thank all of you frontline providers for all the hard work you are doing and the sacrifices you all are making. As a reminder, this is being recorded, and we will be distributing handouts, recordings, and a number of reference tools at the end of the day. Things have been changing quite rapidly. Nicely for us here, there haven't been changes to the rules in at least 2 days, so we haven't had to rush to make updates to a number of presentations, and there's been some nice clarity provided by CMS. So we're going to cover a number of things. There's a question and answer drop down on the GoToMeeting dashboard. Feel free to use that to submit questions. You can use the chat box if you'd prefer. Handouts can be downloaded from the handout drop down, and again, we will ensure that they are sent out to participants as well. So the last update we made was as of 2 days ago, as there haven't been changes since. And as you know, this disclaimer is here so that you're aware that the information was current as of then. We're going to talk about a number of the non-face-to-face type services that can be rendered during this emergency. Please note there are more non-face-to-face services than we're covering. We're not covering them all, but we're going to focus on the virtual visits and what changes were made to those. Telephone services, which are new as of this week, newly approved by Medicare. E-visits, and telemedicine. Remember that all of the services we're going to talk about require that the patient give at minimum some level of verbal consent to be treated on a non-face-to-face basis, so to be treated quote-unquote virtually, and the patient has to initiate all of the billable services. What's changed since the emergency? Well, a couple of things. The Office of Inspector General, the OIG for Health and Human Services, has said that they're not going to look at providers as providing inducements if you're waiving copays and or deductibles, patient responsibilities. But I would caution that this should be done on an as-needed case-by-case basis by practices. Cash flows are down, and some patients are able to pay their copay. I've given this personal example for the last 2 weeks. My son had a sports medicine visit just yesterday, and because at this point I can afford to pay the copays, we paid our copay, and we'll expect to continue to do that for the office visits and or telehealth visits that I'm availing myself of the providers that I need to see, right? But it doesn't mean that all of your patients can afford it, and I think it's a good time to have a discussion on a practice level as to, okay, when are we waiving these and how are we discussing this with patients? Because obviously you can't be discriminatory, but if a patient has a need and the practice has the ability, know that the federal government isn't looking at you as a bad actor for waiving these copayments or patient responsibilities. Additionally, because of the emergency, there have been a number of states that have adopted cross-state telemedicine type allowances where they have dropped their state lines and a lot of boundaries to treating patients across state lines through telemedicine. Please note that scope of practice and licensure rules still apply. So if you're a non-physician practitioner, an NP, a PA, or another type of practitioner who can bill services, and you have a certain level of autonomy in the state of, let's say, Florida, that doesn't mean that the autonomy is the same in a state like New York or Georgia, right, North Carolina. So please make sure that you are aware of any scope of practice restrictions, licensure restrictions that may apply even though the states have said you can treat across state lines. Additionally, very nicely, in this push to provide virtual or tele support for patients, the Office of Civil Rights has said they are going to basically halt enforcement activity and waive penalties against providers that are making good faith efforts to treat patients through what might be non-HIPAA compliant technology. So there are some platforms out there that are considered HIPAA compliant. There are some that are arguably HIPAA compliant, and there are some that are not. What the Office of Civil Rights has said is if you're making a good faith effort to use something like, I'm just going to use for argument's sake, Skype as an example, whereas Skype for Business says they're HIPAA compliant, but Skype on its own says it doesn't say that it's HIPAA compliant, right? They're not going to penalize you for that. They don't expect you to use something like a Facebook Live, right, where a number of people can just log in and see the encounter. But if you're making a good faith effort to treat a patient through teletechnology, don't expect the federal government to come after you for any HIPAA violations based on those good faith efforts, which is nice. Here is the excerpt from the Office of Civil Rights, so you know it's not just Acevedo Consulting saying it, right? Feel free to visit the link. There have been multiple frequently asked questions and additional guidance put out by the Office of Civil Rights to address this issue. Talked a little bit a moment ago that patients have to verbally consent, right, and initiate these visits. What do we mean by that? Remember that there's no formal consent form that has to be captured. What we mean is that the patient has to give the green light to be treated virtually and has to be given an understanding that their patient responsibility copays may apply. You can capture that verbally, you can capture it at the time you're scheduling a visit. You can capture it at the time of the non-face-to-face service. But it does need to be captured and documented somewhere at the patient record level. I would probably, if it were me, have my office managers and or office staff, as they're reaching out and scheduling patients for these virtual blocks, right, obtain the consent at that point verbally, document that it was obtained. I would obtain it for the whole suite of telehealth services, right, telemedicine services, and make sure that it's documented in the patient record so that you have it on file. You don't need to capture the patient's consent every time you talk to them. You can capture it for the year, right, to be able to render these services. When we talk about the initiation of the service and the patient needs to initiate the service, we mean the patient has to have a presenting problem or an existing follow-up that you're managing, some type of annual medical necessity or screening services that has the requirement. What CMS means by patient has to initiate it is that you can't just start soliciting visits because volumes are down and you have the ability to bill for phone calls or telehealth now. So you can't just pick up the phone and say, you know, hey, Mr. Acevedo, this is Dr. Smith, just checking to see how you're doing, and then bill for that. It's not something you're able to do. There has to be a presenting problem, either already in existence and or the patient has to communicate one to you. You can then dial the patient, call the patient, initiate the telecommunication with the patient, but the problem has to be identified by the patient. And you can let your patients know that these services exist. And again, a good time to do that is while you're trying to schedule patients out for the next few weeks and or months as calls are coming in, right? I would have my staff prepared with some type of script that goes over, hey, here's what would be included in a consent if you were at the office, right? So we want to make you aware that for all of these virtual means of treatment, right, you are in a different location from the treating provider. There may be limitations to the technology. Your image may be recorded, your voice may be recorded. You may disconnect. The voice component and visual component may not work in sync like they're expected to, and that deductible and coinsurance applies. Is that going to be a problem for you, right? So have the patients be put on notice, capture somewhere the fact that the verbal consent was obtained, right? Date it, have your staff member's name, and do that proactively so that it's captured and you don't have to worry about every time a patient's contacting you during this emergency having to recapture it. Let's talk about visits. We'll start with the virtual visits. Those are not new as of the emergency. They started back in 2019. The first of these visits is captured through the G code 2010, and that's the patient submitting an image or a recording to you, and the billable provider, the physician or non-physician practitioner, interpreting that image, that recorded video, and getting back to the patient. Haven't seen this used much, but it does exist. The virtual check-in is something we've seen used quite frequently during this emergency, and especially since prior to this week, there weren't other telephone services available to be billed for. So this is a brief communication with a patient, a check-in to see how they're doing, what a next step is. What's new about this code is that during the emergency, these services can be rendered to new or established patients. So if you would have attended this webinar last week or even on Monday, it would have been for established patients only. But since the declaration or enactment of the CARES Act and some additional work by CMS, this is now covered by new or established patients. Remember, it is only for the interaction of the physician or non-physician practitioner, nurse practitioner, physician assistant, certified nurse specialist. If you can bill Medicare and bill Medicare for an evaluation and management service, you can bill Medicare for this service. There does need to be some form of permanent documentation of the quote-unquote encounter. It doesn't have to be very explicit. I would have it documented something like, right, a patient consented to a virtual check-in over the phone, discussed X, Y, or Z, spent 7 minutes in total, period. That's all you need for these. Again, new or established patients, they're really meant to determine the next step. So I call the office, ask for the doctor, he's available. Dr. Khan, my wife was exposed to a COVID-19 patient at work. Do I need to go to the hospital? No, you don't need to go to the hospital. Monitor yourself. Give us a call if any of the following symptoms are exhibited over the following 5 to 7 days, period. End of story. Virtual check-in is done, and you bill for it, right? Nothing that takes real management over the phone. Then there was the adoption of telephone services. So these are the non-face-to-face telephone services. They were not covered, but as of March 30th, retroactively back through the public health emergency, they are covered services. The pricing on the fee schedule amounts were not loaded as of yesterday. 99441, 99442, and 99443 are for, again, physicians and non-physician practitioners, and they're for a telephone E&M service provided that within the previous 7 days or the next day, there's not an office visit or a billable E&M service that's a face-to-face or telehealth provided, right? So this is a phone call. They're time-based visit codes, 5 to 10 minutes, 11 to 20, or 21 to 30 minutes. The time, the dollars that you see associated here, I have to thank one of the practices who actually did the fee schedule conversion numbers. So these are approximate reimbursement amounts, but they weren't loaded in any fee schedule as of yesterday. But that's the approximate reimbursement amounts. So this is, again, if it's nothing more than a telephone call, so audio only, telephone call, 99441, 4243. It is an evaluation and management service, so there does need to be the presentation of a problem and some medical management done. So, doctor, I woke up with a fever and a sore throat, and doctor says, okay, well, we're gonna take some Motrin. We're going to monitor yourself, and we'll call you back in 3 days, right? So today's visit took 6 minutes to say that, just for argument's sake, right? 99241. When we call back in 3 days to evaluate how the patient is doing and go through some additional management steps, right? So the patient's getting worse. We're now deciding what needs to happen. We perhaps write the patient a prescription, and we take 18 minutes on next Tuesday with the patient. We have 99442. Again, nothing more than a telephone call. For those practitioners who can bill Medicare but can't bill for E&M services, so therapists, clinical psychologists, licensed clinical social workers, right? They have the ability to bill for telephone assessment and management services. Same time thresholds. Unfortunately, that lovely client didn't do the math on these services, so we don't have the fee schedule amounts, but I'm sure they'll be posted soon. 98966, 98967, and 98968, and this is for a telephone assessment. So again, there's a problem the patient is presenting, you are managing it, you code these services based on the amount of time, and it's time spent on that day and managing that phone call, right? So it's only the time of the phone call. Important to note that coinsurance and deductible applies. Patient, again, remember, has to consent. It's for new or established patients. Nicely, again, the CMS has expanded this to new or established patients. We do need to document the service. So again, we would want to document the date the service happened, spoke with the patient via telephone, here was the problem, here's what we did, here was the total time. That's all that really needs to be documented from this perspective, from a coding perspective. And both the codes for physicians and non-physician practitioners and the therapists and LCSWs, right, all are expected to be billed without a previous E&M in the 7 days leading up to the telephone service or within the next 24 hours. So these are very simply what you're able to bill if a patient doesn't have telehealth technology and all you can do is talk to them over the phone, or if all they have at the moment is a telephone and you render a telephone-based visit. These are the visit codes that you would use. There's also the e-visits, online digital evaluation and management services. These are also were in place prior to the emergency, but there are a couple of changes. These are now for new or established patients. So if you were to, again, listen to this prior to the 30th, they were only for established patients. Now new or established patients, retroactive back to the start of the emergency. It is for cumulative time in a 7-day period. Very similar time thresholds to what we just talked about, but this is for cumulative time in a 7-day period. And this is for when a patient sends you some type of request through your secure portal, through email, through texting. Remember that the HIPAA waivers are allowing, right, you to use text messages, which we weren't trying not to use before, but this is the patient communicating with you through some online digital means. Perhaps your EHR has an app, right, that you're able to communicate with patients on. The codes represented are based on cumulative time spent in a 7-day period. 5 to 10 minutes would be 99421, 11 to 20 minutes 99422, and 21 or more 99423. That's for physicians or non-physician practitioners. They also have codes available for those non-physician practitioner billable providers, G2061, 2062, and 2063 for those therapists, clinical psychologists, LCSWs. Again, same guidelines apply. It's your time spent accessing and reviewing that initial inquiry. So if it takes me, a minute to open the email and read it, it takes me another 2 minutes to pull up the patient's EHR record and review, okay, get familiar with this patient again. What were the last lab values they had? What was the last diagnostic imaging perhaps, right? That takes another 5 minutes or so. So now we're at 9 minutes. I decide that I'm going to write the patient a prescription and or order a diagnostic test. That takes another 3 minutes. So now we're at 12 minutes. And then I call the patient back and speak with them for another 9 minutes. We're now at 21 minutes, right? Or I formulate an email to them that takes 9 minutes to go over all of the things. We're at 21 minutes. We would bill the 99423, right, if we were a physician in this case, for the 21 minutes or more, for all of the time spent in a 7-day period in a cumulative nature, addressing that initial inquiry from the patient. There is no limitation to where the patient is. These are for new or established patients. We do need to have permanent documentation, so somehow the written correspondence and all of the back and forth need to be accounted for in permanent documentation. You may document in the EMR, right, received, let's just say for argument's sake, the patient sent a text message. So received a text from a patient on April 3rd regarding the following. You document the problem, document what you did, how much time you spent in total, and make sure that that's documented in the medical record as permanent documentation. And remember that deductible and coinsurance would apply, right? So whatever decision you're making as a practice to collect on these would apply to this as well. If in the 7-day period, if within that 7-day period that we're accounting for the cumulative time, you have an in-person or tele-E&M visit rendered that is related to the same problem, you would only bill for that E&M visit. You wouldn't also bill for the time you're spending in the 7-day period. So if it's for separate problems, you're okay, but if it's for the same problem, the work value or the work you did would be rolled up into that evaluation and management service. So we've talked about the first three, right? We've talked about virtual check-ins, we've talked about telephone only, we've talked about e-visits. Now let's talk telemedicine, telehealth for a moment, and then we will make sure we have time for questions. So telemedicine, remember, existed prior to the emergency, and traditional telemedicine was a distant site where the physician or treating provider was located, the patient was at an originating site, and there was live video conferencing that took place through shared technology. And that still exists today, right? And there are some practices that are providing traditional telemedicine still today during the emergency. But because we had a telehealth emergency, a COVID-19 emergency, they've expanded telehealth. And prior to the public health emergency, this isn't an all-inclusive list, but you can see there were all kinds of service codes listed. And there were office visit codes, there were annual wellness visit, smoking cessation. You can see that prior to the public health emergency, when it came to hospital visit codes, there were only subsequent hospital visit codes, and there was a limit to how often they could be done. Same thing in nursing facilities. This was prior to the emergency. And there was the additional burden of the patient having to qualify in a geography and go to one of those originating sites. So during the emergency, what happened, right? Because if you have to go to one of these originating sites and we're on what's otherwise called a lockdown, right? We're not going to be able to treat these patients. So the CMS recognized that. They couldn't change the telehealth law, but what they could do is provide a waiver for a workaround. And what this generally does is state that during the COVID-19 emergency, we are going to recognize non-traditional telehealth. And that can be when the patient is wherever they are and the doctor is wherever they are. And we will work around how to bill those and make sure that doctors continue to get paid what they would have gotten paid if the patient were to be seen in a normal setting, and the patients are able to have treatment without having to leave wherever they are, right? So they could be in their own home, they could be staying with family, right, and be quarantined with family. They could be at nursing facilities, hospitals, wherever they are, and wherever the doctor is now qualifies for the provision of telehealth. And the other thing that's important to note is that the definition of telehealth didn't change. Telehealth is still interactive, audio-visual, real-time communication. Patient can see doctor, doctor can see patient, and you can hear and see each other in real time. That didn't change. While the kind of practitioners, right, are range from physicians all the way through nutrition professionals, the state laws may have dropped some of their restrictions on treating against state laws, but it still is telehealth. And there's been a lot of questions about, well, what about when a patient just has a phone? We keep hearing that, we're allowed to do this over a phone. And some of that confusion came out when Medicare changed, right, had this interim final rule where they had to address phones because smartphones and technology that are now referred to colloquially as phones need to be included, right, in the definition of telehealth, because previously phones were audio only. So they came out and said, okay, we're going to make sure everyone's aware that for the duration of this public health emergency, interactive telecommunication system means multimedia communication that includes, at minimum, audio and video equipment permitting two-way real-time. So it can, whatever the device is, a tablet, a phone, a computer, if something gets invented tomorrow, right, that permits two-way real-time audio and visual, it's okay for telehealth. And the expansion, right, and revisions are expected to end when the public health emergency ends. As you saw on the previous slide, right from the regulation, it says during the COVID-19 emergency. So it's specific to this emergency. And there are other sections of regulations that speak to exactly what telehealth is and the fact that it needs audio and visual capabilities. Then there was the matter of ensuring that physicians and healthcare providers are paid the right amount. And prior to this week, so this came out on Tuesday, March 31st at about 4:30 p.m. is when I got it. Prior to this week, there was a ton of guidance from Medicare saying don't use modifiers and use place of service 2 for telehealth. Well, they listened to the stakeholder community who said on multiple occasions, hey, when we're submitting our telehealth claims, we're either getting denied by the MACs or when we get paid, we're getting paid facility rates because the place of service 2 is making the MAC think that we're providing regular telehealth where there is a distant site and an originating site. That's not the case for non-traditional telehealth. So embedded in this, MedLearn Connects, if you were to click the link in MedLearn Connects for the billing professional telehealth services during the public health emergency, it would take you to what I've excerpted here. This is a direct quote. The only difference is I've bolded this sentence that makes it clear. When billing professional claims for non-traditional telehealth, so this is patient is where they are, you are where you are, right? No formal telehealth. With dates of service on or after March 1st for the duration of the public health emergency, use your normal place of service code, not place of service 2, normal place of service code, and a modifier 95 so that we, Medicare, know that this was done via telehealth. Do not use modifier CR. Do not use the other modifiers unless you are in a position like an acute stroke or if you're in Alaska and Hawaii and you're in a demonstration project. But for the rest of you, right, modifier 95 is what's to be used and place of service that would normally be on your claim form. If you use place of service 2, they're going to think you're rendering traditional telehealth and you will have your payment reduced. Right, so this was Medicare's workaround to the rule that's in place, right? Don't use place of service 2, use modifier 95 along with your normal place of service code. And this is for telehealth. So on the Medicare stakeholder call that took place on Tuesday of this week, we had an opportunity to ask CMS directly. So I'm the questioner here. This is me. Chris Acevedo is the questioner asking a couple of questions, and I thought that these would be helpful for the group as well. So I asked, you've released additional telehealth approved codes, home visits, domiciliary visits, and the provider rendering these services would likely not be there, would be at a distant site, right, an office location or their home. Should they be using office codes or home visit codes if the patient resides at home? And CMS's response was, they should use the code that best reflects the care they're furnishing. And it should be based on the location and the location of the practitioner. And this is a unique set of circumstances. And what they meant by that is, if you would normally be seeing patients in the office clinic, use your clinic codes. If you would normally be seeing patients with home visit codes, use your home visit codes. If you would normally be using SNF codes, use those codes, right? Nursing facility codes. And I wanted to make sure that's what they meant, so I asked the follow-up, right? I asked the follow-up. So if it's a normal fee-for-service, clinic-based practice, you'd use your normal office visit codes, regardless of where the patient is. But if it's a type of home-based service where you'd normally be billing home-based codes, whether it's hospice or Part B home or palliative care, you'd use the traditional code you've been using all along with the 95 modifier, correct, right? So if you're an office-based clinic and you would normally see patients outside of this emergency in your office and you bill 99201 for a new patient through 99205 and you bill established patient codes 99211 through 99215, you're going to bill those codes regardless of where the patient is, if they're not in an inpatient setting, right, regardless of where the patient is, with your normal office place of service 11 and modifier 95. If you are a palliative care practice or a home-based provider and you normally bill your home visit codes, those 9934 whatever codes, right? You're going to still bill those codes. You're going to use place of service 12, and you're going to use modifier 95. If the patient's in the hospital in the inpatient setting, and you would normally go to the hospital to see them and round on the hospital in some capacity, but you're doing this visit via telehealth, you use your hospital visit codes, just like normal with the hospital visit place of service and 95 modifier, right? So normal place of service, normal billing codes, and 95 modifier. And because of this additional guidance, Medicare approved 80 additional telehealth codes. This is not an all-inclusive list, but here are a bunch of the ones they included that are relevant, right? Emergency department visits were not on the list prior to this. Subsequent observation and initial observation codes, initial hospital care codes, initial nursing facility codes, critical care, rest home, domiciliary ALF codes, home visit codes, right? These are now all approved telehealth codes. The frequency limitations that I showed you earlier on the subsequent hospital visit codes have been lifted, right? So they as close as possible to doing business as normal, except shifting the delivery of those visits from face-to-face in-person to telehealth, real-time audio-visual is what they expect. Normal visit codes with normal place of service with the modifier 95 appended to the end of them. There were also some additional psychotherapy, therapy, and LCSW codes, right? The complete list of codes can be found on Medicare. Note that for some of these non-physician provider types, there are additional restrictions via telehealth that you want to check on. So don't just look up the code and see if it's approved, but look to see if under what circumstances therapy codes can be billed and things like that, right? So nicely, these are considered the same as in-person visits and paid at the same rate. Right, so it's bad enough that your volumes will be down. Nicely, CMS isn't also reducing the payment amount. So please make sure that you bill the right place of service so that it's not reduced. Modifier 95 for telehealth services. So those other types of non-face-to-face services that weren't telehealth, you don't need modifier 95, but for telehealth, modifier 95. Make sure if you have malpractice that you're covered for telehealth, and if you're going across state lines, that you're covered to care for patients across state lines with malpractice. We know that, despite all best efforts and good faith intentions, we know how litigious some members of society can be, right? Remember that even if you're treating over state lines, that licensure requirements, scope of practice, standards of care, those all still apply. For any of the evaluation and management service visits that you're billing, so whether they're hospital visits, nursing facility visits, ED visits, office visits, home visits, ALF visits, right? Remember that the documentation requirements still apply. So when you're thinking about how to document these, they should be documented on whatever normal templates you were using before the emergency, whether you're on paper or on EHR, EMR. I would probably start every visit with, after receiving patient consent, the following visit was rendered via telehealth technology, period. And then go about my visit as normal, right? Remember that if you use templates and they auto-populate, remember only the exam components that don't take physical touch can be rendered over telehealth. So don't forget to go back and make sure you update your templates so that you're not getting thrown under the bus because you missed the fact that your normal template includes, right, some palpation of the liver or spleen that now can't be done. Remember, you can take history, you can make objective observations, right? You can assess range of motion. Have you asked a patient to show you, right? If they are complaining about pain in their elbow, right? Have them show you the joint. That you can assess mood and affect orientation, right? Things that you can examine without physical touch. Include those components. Remember that all of the other evaluation management components apply. You can code visits based on time, right? Nicely, I'm not sure why they only did this for office visits. Don't shoot the messenger here, but nicely, if it's an office visit clinic code, you don't have to meet the 50% counseling or coordination of care threshold. You can just bill it based on the time. So familiarize yourself with the time thresholds. One of the reference tools we will be sending out with all of the attachments is a little cheat sheet guide with all the E&M codes, the documentation requirements for each, and the time thresholds. For the commercial payers, Medicare Advantage plans, right? Unfortunately, they are so unique payer to payer that we only have a couple that we've been able to get a hold of and have had time to reach out to. Know that Anthem, right, nicely, at minimum through July, is paying both for telephone only and telehealth services. There are modifiers that they require, right, whether it's just telephone or audiovisual. So understand that Anthem has its own rules, Aetna have their own rules, United has its own rules. So effective through June 18th, here are the rules for United. On one of the previous webinars, I had someone come back and say, oh, we noticed on this slide, you said use place of service to and these modifiers. Remember, this is United's guidance for Medicare. You do not use place of service to. You do not use any modifier other than 95 to represent the telehealth service. Remember that all of these visits require medical necessity, some form of the patient consenting, and your normal place of service code, right? The first two are phone calls. One really doesn't include management of a patient's problem. It's just a check-in to see how the patient's doing, what next steps might need to be taken. The telephone services are management services. The documentation should include the fact that the visit was done via the telephone, what the patient's presenting problem was, and what you did, along with the total time spent, and you bill those telephone services based on the total time. E-visits start with a digital communication to you and include the cumulative time over a 7-day period. And then the telehealth visits, real-time, interactive, audiovisual telecommunication with modifier 95 appended to them, right? You can think of them kind of this way, right? There are a number of visits that are under the auspices of telemedicine suite, right? And there are 3 of them that don't require any face-to-face component, right? The e-visits, the virtual check-ins, and telephone service. They don't require any face-to-face component. But the telemedicine service that does is telehealth, and it requires real-time audio and video, right? So you have to be able to see and hear. I've gotten a question often, what about if my visit starts with an audio and video component, and because of the bandwidth or internet restrictions, it switches to audio only? I'm going to say those are okay as telehealth. You made a good faith effort to have a telehealth visit. It just happened to, spaz out on you. That's all right, still bill it. But remember, the documentation requirements for the visit level still have to be substantiated. If it's that a patient just doesn't live in an area where they have an internet connection, or they don't have the technology, can't get to the technology, unfortunately, CMS has not waived those requirements, so those would be telephone-only services. We'll send you, I know this is a little small and maybe blurry for some of you, but we'll send you this reference guide as well to be used during the emergency. It has the virtual check-in codes, the telephone services, the e-visits, telehealth, right, with some guidance and tools. We will send that out to everyone as well. There are a slew of references that are available to you, and again, we will send those out as well. And I want to take some time to go to questions. So if you have a question that you haven't already entered into the question and answer box, please feel free to submit one. So I'll start at the top. I answered this one in writing in the box, but I don't know how this interacts. I haven't been on the other side of this, so I'll answer it in person or on the line. So what place of service code do we use for a telephone visit? Is it where the patient's located or the office code? So for all of the visits, all of these telemedicine suites of visits, right? E-visits, virtual visits, telephone calls, or telehealth, you're going to use your normal place of service code. So if your physicians are physicians that normally see patients in the office, but they're at their home, right? You would still use the office visit place of service of 11. I've got a thank you, so thank you. For telephone call codes, do we need to add a modifier? No, the modifiers that are needed, the 95 modifier is only for telehealth, which are the real-time audio-visual, And obviously, if there are other things that are done, so if you have a patient coming to your office for an injection, but you're also rendering a separately identifiable tele-office visit, then on that claim form, in addition to the 95 modifier, you'd have a 25 modifier on the E&M, right? And then the 95 modifier for telehealth, and then your injection service, if they were showing up to your office and all of this was getting done on the same day. Okay, so a question about Incident 2. So for Incident 2 services, the rules for Incident 2 still apply. So you would have to have both the supervision requirement of a physician and the billing provider met for an established patient with an established problem that the patient has a problem that the physician created the plan for. When it comes to physical therapy, there are some physical therapy codes that have been approved, and unfortunately at this time, right, there does need to be a physician involved supervising the physical therapy. A therapist on their own can't be billing these telehealth codes, is my understanding with how Medicare approved them at this point. I expect some more changes. For patients, consents being applicable for the year, is that strictly in response to COVID-19, or is that a standard practice? Good question, Jamie. So I would say for these virtual visits, because remember, the non-face-to-face services, right, were in existence prior to the public health emergency and will continue after. I would say they're good for the year after the emergency. As a form of customer service, you may want to remind the patients and get it again if your practice is going to continue with virtual visits. But I would say if you get their verbal consent or written consent once a year at least, I think you're covered. So good question, Jamie, as a standard practice. Patient contacting a physician via an answering service. So I would say if the call back to the patient involves management, you can bill the telephone visit codes. Not a problem. And just remember, you'd want to document the total time, what the problem was, and how what you addressed with the patient. Can I bill telehealth visits for new patients? Yes. So the telehealth visits, so audio and video, thanks for putting that in parentheticals, James, are for new patients and established patients. You can, it counts if you get a consult request. So if you get referred, right, you're a specialist and a PCP refers a patient to you, that counts as the initiation of the service. And so you can call the patient and say, hey, we understand that, Dr. Smith referred you. Do you consent to these televisits? And are you available, Tuesday at noon? No problem. Can you code 99441 through 99443? So those were the telephone visit codes every 72 hours. So they're really meant for when you have phone calls with a patient. So if you have a separate phone call 3 days in a week for 3 separate issues, you definitely can code each of those based on the time values. If they were all related within a 7-day period, you probably should only bill the last one because they are still E&M services, and they do say they shouldn't be billed for related E&Ms within a preceding 7-day period. So good question, Rachel. All of the services we covered, everything telehealth, telemedicine, e-visit, virtual visit, are all for new and or established patients. So good question. I know that previously it was only for established patients, a lot of these. This is for new or established patients. So good question. Okay, patient committed to telehealth, not able to connect despite multiple attempts. Convert the app to telephone only. Is this telehealth or telephone? And so this is a good question, Jaishri. I have to say that I'm not happy with my answer, right? My answer is based on the guidance that CMS has. If it ends up being telephone only, if that's what happens, then it's only the telephone codes. If you stay on the telehealth technology and it, for whatever reason, for bandwidth problems, switches over, I think you'd be okay to bill them with the office visit codes and use telehealth. But if you're switching to a phone call, then it's telephone only. And I have to say I'm not happy with my answer, but it's based in the guidance that I have currently. If there are any updates, we'll be sure to let the group know. I do know that CMS is trying to be as flexible as possible, and I also know that many of you have had issues, right, getting the connectivity that's needed with your patients and getting them able to. I've had physicians call me with just general frustration saying, you know, it's taking me 15, 20 minutes to get a patient connected, and it's not sustainable to do that with all my patients. So I'm aware of that problem, and I know CMS is aware of it, and hopefully they make some additions. Laura asked a question about modifier 95 with the telephone visits. Nope, only for telehealth. So only when you're billing your normal visit codes, right, that you were billing prior to the emergency. So office visit, home visit, SNF, hospital. If those are being rendered via telehealth, you use the 95 modifier. Question about place of service. Use your normal place of service codes. Whatever you were using to care for your patients prior to the emergency, use as a place of service. If you weren't using e-visits or virtual visits before, well, what were you using on your normal office visits? Probably place of service 11 if you're a clinic-based practice, use those. If you're a provider-based billing practice, use what you normally bill, 19 or 22, right? And those of you who are provider-based billing practices, you know who you are, so that wouldn't change for you. Normal place of service codes. The difference here is if it's telehealth, then you use 95 modifier. Otherwise, your claims are going to look pretty much just like normal. Patient asked to review some data sent by someone else or required going into hospital records. So I'm assuming when we mean sent by someone else, I mean it's like another provider, but it's for the patient, right? So Bruce, so patient sends you some data to review prior to speaking with them, and or they've sent you a request to review some records prior to the visit. So if you're having some interaction with them and not just responding via email, because if they're sending you, if it's an image or a recording, right, you have that that G2010 visit code. But if it's what I think you're talking about, right, patient is sending you an interpretive report of an MRI or an ultrasound or some diagnostic test, and you're reviewing it, and then you're getting back to the patient, you would use for that those e-visit codes, those digital online evaluation and management codes to represent the time you spent opening their request, reviewing it, committing your mind power to it, formulating a plan and getting back to them. That's what you would use, unless, of course, it ended up that you decided to tell your office, you know what, schedule a visit based on these results, a televisit, and then you'd bill telehealth with your normal office codes, your normal place of service, and the 95 modifier. Hello, Dina and Doreen. If the provider calls an inpatient and video doesn't work, do we bill? Good question. So if the patient is in the hospital and you're not able to connect via telehealth, and you're rendering, so this is a cardiology practice, right? So you're rendering physician services. You're telling the patient perhaps it's a patient who went into AFib, maybe had a stroke, and you are going over whether or not you're going to start blood thinners with the patient, and you're doing it over the phone. You would use the telephone codes, and you would use the hospital place of service if the patient is an inpatient, which I'm assuming is your question here, and you'd use the hospital place of service and the telephone codes. If you got to them via telehealth, then you would use the hospital place of service. You would use the 99231 through 33 subsequent visit codes if it's a subsequent patient, like you have here in your example, and you'd use the 95 modifier. So good question. Do we have to use place of service 11 and modifier 95 for non-face-to-face like telephone only? So again, I think I answered this, but just in case, for non-telehealth, so when there's no video component, you use your normal place of service. So it's 11 if you normally see patients in the office. If you're a home-based practice or a palliative provider and you normally see this patient at home, you would use 12, which is home. If you're a SNFist and you're normally seeing a patient in a nursing facility, you would use the nursing facility place of service, right? But the normal place of service, and you would not use a modifier 95 if it's not telehealth. Okay, need to call each insurance plan. So yes, Angela, you do need to call each insurance plan. Unfortunately, I'm not able to get that information, and so you do need to call each insurance plan and verify what their requirements are. And I had one more question about place of service code. So I'm gonna say it one different time. So for place of service codes, if it is telehealth or not telehealth, you use your normal place of service code. Do not use place of service code 2. I know, Val, I know I've seen your name. You've been on previous presentations. And prior to this week, I know we said use place of service 2, but that changed on Tuesday of this week. So do not use place of service 2. You're not rendering traditional telehealth. You're rendering non-traditional telehealth, which is because of the emergency. So no place of service 2. If it is telehealth that you're rendering, the only difference is you're going to add a 95 modifier. So for all of your patients, and this kind of goes for everyone, right? If you're treating a patient via telehealth, that the way to think about this is, how would I have billed this before the emergency if I would have seen them normally? And you're going to use the place of service that you would have normally used. And then the only time you're going to trigger to something additional has to happen is if it's a telehealth visit. And if it is, you're going to append modifier 95. That's the easiest way for me to say it. The virtual check-in codes. The virtual check-in is the G2012 for the brief telephone call check-in, and the other virtual visit code is G2010. That's the patient sending you an image or a recording, and you interpreting that and just getting back to them. The E codes are the patient is asking you a question, getting a problem, and there's some management of that problem needed. Doesn't mean you're writing an order or a script. It could mean that, but there's some management of the problem. And the e-visit codes are for cumulative time over a 7-day period. The virtual check-in codes are just in the moment. There's no time associated other with that. It's generally a brief 5 to 10 minute call. One question about the waiving of greater than 50% of counseling coordination of care. Can I expand upon that? So that is only if it's an office visit. So if you're billing with the 99201 through 05, new patient office code, or 99211 through 15, established patient office codes, you can just use the times if you need to without having the code have to qualify for time with greater than 50% of counseling coordination of care. If it's still not clear after this, I don't want to derail anyone else. So Dr. Okiki, please feel free to email me offline, and I'm happy to go through it with you. Good question, Alex, about whether or not to refile claims. So we know some of you have been had been proactively doing these visits all throughout the last couple of weeks, and you may have already submitted claims, and you may have submitted them with place of service 2 because that's what was asked for at the time. So I'm going to say, as of right now, I would contact First Coast and see if they want to reopen the claim. I expect Medicare at some point to provide some more global guidance and say, hey, if anyone submitted claims that were processed during this period, the MACs will automatically reprocess the claims and you won't have to do anything. So Dr. Graniff, you may just want to wait a little bit on those. If they got denied, go ahead and refile with the correct place of service and modifier 95 if it's telehealth. If you got paid the lesser amount because they paid a facility rate, I would flag those, and I'd wait a little bit because I think Medicare will probably require the payers, the MACs, to do automatic reprocessing. Any other questions? Oh, this is a good group. Wonderful. Well, okay. So another question about modifier 95 and telehealth. Remember, telehealth is only real-time audio-visual synchronous communication, and that's the only services you're going to use modifier 95 on. Only when it's telehealth. That's it. For telephone, do we have to do history? So good question about the telephone only visits, right? Do we have to document them with, history, exam, medical decision making? No. You do have to document what the patient's complaint was. So what the history is, what's the presenting problem, the reason for the visit, a chief complaint, right? And then you would document what you did, but you don't have to worry about all the bullets, right, that you do for billing a telehealth visit or an in-person visit. The telephone calls are strictly time-based. They're 5 to 10 minutes, 11 to 20, and 21 to 30, and you bill those based on the time, and that's it. But you do have to document, right, that there was a problem you managed. Again, question about the lesser amount being paid because of place of service 2. Nicely, thank you. Hymanat has said that they've submitted corrected claims online and gotten corrected payments. They're with Novitas in Maryland. So again, you may want to wait. You may want to submit corrected claims, but I know the payers will make this right, and you will eventually get the right amount. But make sure you flag somehow any visits that you did bill with the wrong place of service and that did either get denied or paid at a lower level, and take them up with your payer at the appropriate time. It may be now, it may be a month from now. Normal place of service for all billing, exactly. Doesn't matter, telehealth or not, normal place of service. Thank you. All right, so I'm happy to have any of you, and if any of you are still confused or need some follow-up, please reach out to me offline. We can talk. It may be best to talk over the phone rather than email, so we can go through these. Feel free to reach out to us. We're happy to help. We've been doing it for the last 3 weeks at no cost to anyone who's calling or emailing. It's the least we can do for you all being on the front lines. Thank you so much for what you're doing with patients. My heart goes out to you. Our deepest gratitude here at Acevedo Consulting goes out to you for all you're doing on the front lines. Please feel free to reach out with any follow-up needed. You will be receiving a copy of this recorded presentation along with the handouts and a number of reference tools and materials. And I hope that all of you stay safe, sane, asymptomatic, and absolutely loving your loved ones. Have a wonderful weekend, and thank you.